Today, let's continue with nephrology. So, let's see the basic structure of kidney. The nephrons are the functional unit of kidney, which consists of a glomerulus, which is the capillary tuft, the blood vessel, which is getting into the taking blood into the glomerulus, is called the efferent arteriole, which is A, and the blood vessel which is taking it out from the glomerulus, it's called efferent arteriole. And these vessels, they run around the Henle's loop, which is called the vasa recta. So we have the glomerulus, then we have the Bowman's capsule, we have the PCT here, which is the proximal convoluted tubule. This is called a Henle's loop, which has a descending limb and ascending limb. Ascending limb is a bit thicker, and this is the DCT, distal convoluted tubule, which connects to the collecting tubule. Many of the collecting tubule drains into collecting duct. Okay, and we have the cortex and the medulla. And as it moves along, the urine gets concentrated. Majority of sodium gets reabsorbed at PCT. So these are the major points that you have to know. And one more thing is, when I just put the picture here, I just want to remind you about the mechanism or site of action of different diuretics. So you can remember it using a mnemonic called P. Okay, this is based on the site of action of different diuretics called P, which stands for C4 carbonic anhydrase inhibitors, which is like acetazolamide, which acts at PCT. Okay, because that is the first part. Then O, osmotic diuretic, which acts as loop of Henle. L for loop diuretic, like your furosemide, which acted ascending limb of loop of Henle. T for thiazide diuretic, which acts at early part of distal convoluted tubule. P is for potassium sparing diuretic like spironolactone, which act at the distal part of DCT. Okay, so this is about the structure. Now, the renal diseases in children or in adults can be glomerular, it can be tubulointerstitial, it can be vascular. Okay, this tubular diseases like your renal tubular acidosis and all, maybe it can be toxin mediated, it can be due to some other autoimmune diseases, it can be due to drugs like acetazolamide can cause renal tubular acidosis and all. Now, the glomerular diseases, it can be due to some other genetic mechanism like in Alport or familial syndromes, or post-infectious like post-streptococcal glomerulonephritis, etc. And there are vascular disorders also. So today we are mainly focusing on the glomerular disorders. So this is again a closer picture of the glomerulus. The glomerulus has three layers. The inner is the endothelium, which is the capillary wall layer. And then we have a basement membrane, which is called the glomerular basement membrane. And then we have the podocytes, which is the epithelial podocytes, which are like the food processes. In minimal change disease, the only change that we can see, that too in an electron microscope, in the normal microscopic appearance, there is no change. There is only proteinuria, and there is the effacement of podocytes in electron microscope. This is the change seen in minimal change disease, and this is the most common cause of nephrotic proteinuria in children. Okay, and in between the podocytes you have a slit diaphragm. So this is structure of glomerulus. So first you have to understand what is a nephrotic syndrome, what is a nephritic syndrome. So what is the difference between nephrotic and nephritic syndrome? Nephrotic is mainly the edema, proteinuria. Okay, so there is proteinuria, there is edema, and it is massive proteinuria, which is more than 3.5 gram per day. So in effect, there is low serum albumin, less than 30 gram per liter, and there is dyslipidemia, or hypercholesterolemia, and hypercoagulability, because antithrombin 3 is lost, because with all the proteins, antithrombin 3 is also lost through urine, so there is hypercoagulability. there is reduced immunity because immunoglobulins as well is lost. Okay, so the complications of nephrotic syndrome can be thromboembolism and infections. Peripheral edema in adults, facial edema in children, frothy urine because of loss of protein, fatigue and recurrent infections again due to loss of immunoglobulins. And the proteinuria is massive, 4 plus proteinuria. Hematuria may or may not be present. It is not that once you see RBCs it is always nephritic. No, in nephrotic also, because some of the disorders are not purely nephrotic. They are a mixture of majorly nephrotic with a bit of nephritic pattern. So RBCs can be seen in nephrotic as well. Red blood cell cast is usually absent, and the causes are mainly minimal change disease, most common in children, membranous nephropathy in adults, which is also possible that there is an underlying malignancy like a lung cancer or any other malignancy. So you have to work up for the malignancy workup or a cancer workup in an adult who is presenting with a membranous nephropathy kind of picture. FSGS, which can be a complication of diabetic nephropathy also. Now, nephritic syndrome, there is mainly hematuria and hypertension. The proteinuria is minimal. There is also mild edema. Temporary oliguria and uremia can be there. So, hematuria can be again frank or microscopic. Edema is mild, oliguria and signs of uremia, which are fatigue, pruritus, and nausea. Proteinuria is only 2 plus, but hematuria is significant with RBC casts. The causes are IgA nephropathy, post-streptococcal glomerulonephritis, RPGN, which is rapid progressive glomerulonephritis, which is also called the crescentic glomerulonephritis, which is having crescentic deposits in the glomerulus. Okay, crescentic glomerulonephritis, and it can be subclassified into anti-GBM, vasculitis, and others. We'll see the detailed version of these in the video. Now, these are the main diseases which is manifesting as acute glomerulonephritis, which is post-streptococcal glomerulonephritis, IgA nephropathy, Goodpasture syndrome, and rapidly progressive glomerulonephritis. Okay, so post-streptococcal, the mean age is 7 years. Okay, it is mainly in after a streptococcal infection around 2 weeks later. Okay, there is a latent period of 1 to 3 weeks, and the lab findings are raised ASO titer with positive streptozyme, decreased in complement levels. Okay, and the immunofluorescence is granular IgG deposition with subepithelial humps. This is important. It is subepithelial humps. 95% resolve spontaneously. 5% may go into rapidly progressive glomerulonephritis or slowly progressive. You have to monitor for oliguria, hypertension, and treat appropriately. You have to control the blood pressure and all. That is the management line in nephritic syndrome. In nephrotic, mainly you are focused on the cholesterol levels. You are focused on the infective the predisposition to infection. So you are mainly treating it with steroid. IgA nephropathy. Now there are two terms you have to understand and differentiate. There is IgA nephropathy and IgA vasculitis. It is almost similar because there is IgA deposition. Okay, IgA in the dermal capillaries, and the immunofluorescence also shows diffuse mesangial IgA deposition, and there is mesangial deposits in this. But the difference between vasculitis and IgA nephropathy is that IgA nephropathy is it is limited to the kidneys, but IgA vasculitis is a more general phenomenon. It's a vasculitis, so it has other manifestations as well. It was previously called Henoch only in purpura. So there is purpura, there is abdominal pain in a child, and IgA deposition, you think of HSP. Otherwise, you think of IgA nephropathy. More or less similar because both have similar manifestations, but HSP is a bit more broader because it is vasculitis and not just limited to the kidneys. and it follows usually viral syndromes. So in a respiratory infection, if it is concomitant with a viral respiratory upper respiratory infection, you think of IgA. If it is after a streptococcal pharyngitis and all 2 weeks later, you think of post-streptococcal glomerulonephritis. Now, good pasture is with an antibody against glomerular basement membrane. So we have seen glomerular basement membrane. So that is what is called good pasture syndrome. It has a linear IgG deficits. What is more important is it has also pulmonary manifestations, which includes pulmonary hemorrhage and iron deficiency anemia. So it can be diffuse proliferation of crescents. Initially it can be focal and then it goes into diffuse. So there is a difference between focal. I'll show it in the upcoming slide, but I'll just make it a point to say it here. What is focal? What is diffuse? So when you, in terms of glomerulonephritis, when you say focal, you mean only some of the glomeruli are affected. Suppose if we say there are a million nephrons in each kidney. So suppose if only less than 50% of the nephrons, total nephrons or total glomerulus are affected, you call it focal. So it is less than 50%. Diffuse means many of the glomeruli are affected. More than 50% are affected, you call it diffuse. Again, if not the whole part of glomerulus, if in one glomerulus itself only some part is affected, you call it segmental. If the whole of glomerulus is affected, it's called global. That is why you have FSGS, focal segmental glomerulosclerosis. That means less than 50% of the glomerulus is affected. In that also, not the whole of glomerulus is affected, only some part of the glomerulus is affected. So here in good pasture, you have pulmonary hemorrhage with positive anti-GBM antibody. Pulmonary hemorrhage is not just seen in good pasture; it's also seen in granulomatosis with polyangiitis. It's seen in it can be seen microscopic polyangiitis. So what is the difference between this granulomatosis with polyangiitis and good pasture? Good pasture, you have antibody against anti-GBM antibodies there. In granulomatosis with polyangiitis, it's an ANCA-associated vasculitis, and there can be other manifestations like sinusitis, okay, and there is pulmonary hemorrhage and all. That is the difference. So, and it is presenting as an RPGN, rapidly progressive glomerulonephritis. So, RPGN usually it is ANCA in some, but in others it can be non-ANCA mediated also. And actually, it is divided into three types. We'll just see that in the next slide. Crescentic glomerulonephritis, that is the other term. There are no immune deficits, and 75% stabilize or improve if treated early in both good pasture and this RPGN. And the treatment can go in for steroids. You can use AC inhibitors in case of IgA nephropathy. Okay, steroids and cyclophosphamide in case of good pasture, against steroid pulse in RPGN. Now, RPGN, as I mentioned, it is classified. It can be classified into primary and secondary, and it can be classified into type 1, 2, 3, 4. We'll just see that. Primary is anti-GBM antibody disease. So, anti-GBM is actually sometimes classified as a subclass of RPGN. It can be anti-GBM, which is called good pasture with pulmonary hemorrhage as well. It can be immune complex mediated or post-immune. Secondary, it can be membranoproliferative, IgA nephropathy, IgA vasculitis, which is Henoch-Schönlein purpura, post-streptococcal, and SLE. That is some other diseases which are usually a very minimal presentation, sometimes progressing into rapidly progressive glomerulonephritis. And the other type where you classify it is based on immune complex mediated, anti-GBM or post-immune. Okay, so there is loss of kidney function over a short period of time. That is what the term suggests, rapidly progressive glomerulonephritis, and there are cellular crescents across the glomerular thing. That is called crescentic glomerulonephritis. There is hematuria and proteinuria, crescent formation, extracapillary proliferation in Bowman space. That is called crescent. Now, immune complex mediated is presence of immune deficits in the glomeruli, which is IgA nephropathy, lupus nephritis, cryoglobulinemia, post-infectious glomerulonephritis, etc. And in GBM there is an autoantibody against type 4 collagen, and it is linear deposition on immunofluorescence. In post-immune, there is minimal immune deficits, negative immunofluorescence, and majority is ANCA positive. And there are two types of ANCA, which is C ANCA and P ANCA. C ANCA is proteinase antibody, and P ANCA is myeloperoxidase. Okay, C ANCA shows cytoplasmic neutrophilic staining, and P ANCA stands for perinuclear cytoplasmic staining. Okay, that was hematuria, that was nephritic syndrome. Now coming to proteinuria, there are other terms also for proteinuria, like physiologic, orthostatic, it can be transient. So physiologic can be orthostatic or transient. Orthostatic is absence of proteinuria in overnight. So when you think of orthostatic proteinuria, or when you have in a child presenting with proteinuria, you have to rule out orthostatic proteinuria. What you do is you collect an early morning sample of urine and check for protein, and if it is negative in 3 consecutive samples, you rule out that there is any organic cause, and you stay there, it is orthostatic proteinuria. Transient is again with exercise, fever, and heart failure, and it also goes on itself. Now the pathologic variety are tubulointerstitial, glomerular, and overflow proteinuria. Overflow proteinuria with multiple myeloma and all, okay, which is the Bence-Jones proteinuria, with amyloidosis, with Waldenstrom's macroglobulinemia, which is the increase in IgM band will be increased. The tubulointerstitial is impaired reabsorption. It is less than 2 gram per day, and it is seen in Fanconi syndrome. The glomerular one is what we are mainly concerned with. It is again primary and secondary. The primary varieties are minimal change, membranous, FSGS, membranoproliferative, post-streptococcal. Why there is an overlap? Because some of the disorders are not purely nephrotic and purely nephritic. There can be overlap, like in PSG and IG and all, there is overlap. It is predominantly nephritic, but it can also cause proteinuria. Systemic disease like SLED and vasculitis, these are the secondary causes. Infectious like HIV, hepatitis B, bacterial endocarditis, Alport, Fabry, sickle cell, medications like NSAIDs, gold, heavy metals, solid tumors, lymphoma, cryoglobulinemia, and hypertensive nephrosis. Okay, again in a proteinuria, how do you work up? If there is protein, you repeat the urine dipstick. If it is negative, it is transient. If it is positive, then you obtain the first morning urine protein. Okay, it is if it is consecutively negative, that means it can be orthostatic proteinuria. Okay, if it is positive, again that means there is proteinuria, so you do a 24-hour urine protein. Okay, if it is significant, then it needs further evaluation to identify what is the underlying cause. Now the main diseases are minimal change, which is more common in children, FSGS, which is with diabetes, membranous nephropathy, there can be underlying malignancy, membranoproliferative, again can be type 1 or type 2. Okay, based on whether there is a dense deposit or normal. Dense deposit is the type 2. Minimal change, okay, it is mainly seen in children. Okay, it does not progress. Usually there are no associated conditions, and there is nephrotic syndrome, and the light microscopy is normal. In only in electron microscopy you see any change, that is called the podocyte effacement of podocyte or podocyte fusion or food process fusion. Immunofluorescence is negative. The remission is after 8 weeks of oral corticosteroid therapy in over 90% cases. FSGS, the age 2 to 10, usually associated with heroin, HIV, sickle cell, reflex nephropathy. It can be seen in adults also with diabetes and all. Okay, that is mainly nephrotic. There are focal sclerotic lesions. Again, as I mentioned, focal means only less than 50% of the glomerulus are affected. Segmental means only part of the glomerulus is affected. IgM and C3 can be deposits can be seen, and again there is food process fusion. Membranous, there can be other underlying malignancies, so you have to work up for malignancy in a patient with membranous. There is thickened glomerular basement membrane and fine granular IgG and C3 deposits, which is subepithelial also. In membranoproliferative, there is dense deposit disease, which is the type 2, and mesangial and subendothelial deposits in type 1. Again, there can be thickened glomerular basement membrane. There are low complement levels, but the type 2 is having normal complement levels. Okay, all the usually the nephrotic type has normal complement levels except for this type 1, which is having low complement levels. So nephrotic syndrome, you have hypoalbuminemia, edema, hypercholesterolemia. Okay, there is massive proteinuria. There can be fluid overload symptoms, dyslipidemia and all. There is scrotal edema, which is also seen with edema in children. Complications include mainly infections because the immunoglobulins are lost, renal failure. It can progress to renal failure, thromboembolism because the antithrombin 3 is lost through urine, a failure to thrive and malnutrition, premature atherosclerosis again from hyperlipidemia. So you have to control cholesterols in children with nephrotic syndrome, and calcium and vitamin D supplementation. Lupus nephritis, they are classified into 6 classes. Okay, 6 classes, and they include minimal mesangial, mesangial proliferative, focal proliferative, diffuse proliferative, membranous, and advanced sclerosing. Minimal is there are no renal findings. Mesangial proliferative is it is a mild clinical renal disease. There is mild to moderate proteinuria. Focal means less than 50% glomerular involved. Diffuse means more than 50% glomerular involved. Membranous means there is significant proteinuria, and advanced sclerosing means more than 90% glomerular sclerosis, and it inevitably leads to renal failure. So these are the 6 types. Now, again, a bit on MPGN, which is membranoproliferative glomerulonephritis. It can be associated with many other infections like hepatitis B, C, infective endocarditis, okay, schistosoma, mycoplasma, and rheumatologic like SLE, scleroderma, Sjogren, sarcoidosis, and malignancies. Again, membranous is also malignancy associated, and membranoproliferative also. Now, another inherited disorder like alpha-1 antitrypsin deficiency, complement deficiency, etc. We'll see an overall picture of different glomerulonephritis and identify different glomerulonephritis. So these are the key terms that would be given maybe in exam. So you have linear GBM, immunoglobulin immunofluorescence staining. So it can be anti-GBM disease. With lung hemorrhage, you call it Goodpasture syndrome. If there is no lung hemorrhage, it is just anti-GBM glomerulonephritis. Okay. Now, if there is granular immunofluorescence staining with immunoglobulin and C3, it is immune complex glomerulonephritis. Okay, if there is dominant IgA vasculitis, it's called IgA nephropathy. If there is IgA with vasculitis, you call it IgA vasculitis or Henoch-Schönlein purpura. It can be seen with SLE, you call it lupus. Again, there are 6 types of lupus nephritis. If there was a history of streptococcal pharyngitis, you call it post-infectious. Thick capillaries and hypercellularity, it's immune complex membranoproliferative. Thick capillaries, but with no hypercellularity, it is membranous. There can be underlying malignancy with that. And there are others like fibrillary or other immune and all. Then granular IF staining for C3 and little or no immunoglobulin, that is C3 glomerulopathy. Again, can be dense deposit with the dense deposit membranoproliferative, which is this MPGN type 2. Now, if there are there is a paucity of immunofluorescence staining for immunoglobulin and complement, it can be ANCA mediated. ANCA mediated, again, if there is no vasculitis, it is just ANCA glomerulonephritis. If it is vasculitis with no granulomas or asthma, it is microscopic polyangiitis. If there are vasculitis with granuloma but no asthma, it is granulomatosis with polyangiitis, and there is sinusitis, there is pulmonary hemorrhage. Now, vasculitis, as well as history of preceding history of asthma, it is eosinophilic granulomatosis with polyangiitis, which is called the Churg-Strauss syndrome. So that was overall, you just need to know the different diagnoses and the key to identifying them. Now, a word on IgA nephropathy versus IgA vasculitis. As mentioned, IgA nephropathy is only limited to the renal. IgA vasculitis has extra renal symptoms, which include skin, there are purpura, there are neurologic manifestations, pulmonary manifestations, along with renal involvement and abdominal pain as well. So it both includes mesangial depositions of immunoglobulins and C3. There is mesangial hypercellularity, okay, and it is more severe in adults, okay. Again, IgA vasculitis is otherwise called Schondlin purpura, and it includes palpable purpura, arthralgias. There can be GI involvement, renal involvement with microscopic hematuria. Serum IgA levels are elevated in 50% cases. And okay, so this is the IgA deposition. Now this is what I have been talking about. Focal means only some of the glomeruli are affected. Diffuse means more than 50% are affected. Global means the whole of glomerulus. Whatever glomerulus is affected, the complete part of glomerulus is affected, it's called global. Only some part of glomerulus is affected is called segmental. That is what you call focal segmental glomerulosclerosis. Only some of the glomeruli are affected, and in that some part only affected. Now, when you have a new onset nephrotic syndrome, how do you manage it? If it is less than 12 years with no syndromic features or family history, you give glucocorticoids. Or if it's more than 12 years, and there is syndromic features or family history, you go for other testing and all. So the main line of treatment is steroid. Now, what do you say when if it is steroid responsive or non-responsive? So, if you give steroids for 4 to 6 weeks and there is no response, then you have to look for other things. That is called a non-responder. Now, if it is a complete responder, you give glucocorticoids for 8 to 12 weeks. And there is relapse because you step down the treatment, and if with step down there is relapse, you classify them again into frequent relapser and infrequent relapser. Infrequent relapser only need glucocorticoids, but frequent relapser will need other modes of immunosuppression with cyclophosphamide, mycophenolate mofetil, levamisole, rituximab, etc. And there are cases which are called steroid dependent, which again can be treated with mycophenolate mofetil, rituximab, and all. So this is the response to steroid in a child with nephrotic syndrome. So what is remission, relapse, frequent relapse, steroid dependence, and steroid resistance? So you do a 3 consecutive early morning specimen. If the urine albumin is nil or trace, which is proteinuria less than 4 mg per meter square per hour, that is the accurate value. So if your urine albumin is nil or trace for 3 consecutive early morning specimen, it's called remission. Now, what is a relapse? That is after having remission, if the urine albumin is 3 plus or 4 plus for 3 consecutive early morning specimen, you call it a relapse. Now, if the relapses are 2 or more in the initial 6-month period or more than 3 in any 12 months, it is called frequent relapse. The steroid dependence is when 2 consecutive relapse when on alternate day steroid therapy. So you step down the steroid into alternate day regimen. In that time you are having 2 consecutive relapses, or within 14 days of discontinuation of steroid you are having relapses. It's called steroid dependence. Steroid resistance means absence of remission despite therapy with daily prednisolone at a higher dose of 2 mg per kg per day for 4 weeks. That's called steroid resistance. So you classify into different categories and treat them accordingly. So that is the response to steroid treatment. Because if they are steroid resistant or steroid dependent, the management line differs. Because if it is steroid dependent, you have to keep on giving steroid. If it is steroid resistant, you have to look for other modes of immunosuppression like cyclophosphamide, mycophenolate, mofetil, etc. Now I'll just talk about the ANCA-mediated vasculitis. So PNCA means perinuclear staining, CNCA means diffusely granular cytoplasmic staining pattern. Now, the PNCA-associated vasculitis are primary vasculitis, microscopic polyangiitis, Churg-Strauss or eosinophilic granulomatosis with polyangiitis, polyarthritis nodosa, and other disease like your rheumatological conditions, FLT, SLE, rheumatoid arthritis, Sjogren, chronic inflammatory bowel disease, chronic liver disease, primary sclerosing cholangitis, etc. CNCA associated are only few. You just remember this, others are PNCA. Vaginous granulomatosis, okay, which is granulomatosis with polyangiitis, microscopic polyangiitis. Sjogren's also can be sometimes associated with CNCA. So we'll see the vaginal and other the main termed things which we know, which we must know the difference between. So vaginous is affecting the lungs, the nasal passage, and kidneys. So in nasal or oral inflammation can be there. Lungs, there is abnormal chest X-ray with pulmonary hemorrhage. Kidneys show microhematuria. Biopsy show granulomatous inflammation. So it is granulomatous with pulmonary hemorrhage with recurrent sinusitis, and the treatment is steroid. Okay. Now, microscopic polyangiitis is vasculitis of small vessels. It is again, there can be pulmonary alveolar hemorrhage, and the treatment is cyclophosphamide, and otherwise you can give methotrexate or azathioprine. Churg-Strauss, also called eosinophilic granulomatosis with polyangiitis. So there is eosinophil-rich form of granulomatous inflammation. So it is granulomatous and associated with asthma and eosinophilia. Yeah, so the treatment is again prednisolone. So how do you differentiate microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and granulomatosis with polyangiitis? So there are three things: granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. Microscopic polyangiitis. So the common symptoms are all causes glomerulonephritis. Okay. There is pulmonary hemorrhage in all of these, but granulomatosis with polyangiitis can affect sinuses, and there can be, it is CNCA mediated. It is CNCA mediated. Eosinophilic granulomatosis, there is history of asthma, there is eosinophilia, and it is PNCA mediated. There can be CNCA also, but usually PNCA. So here there is asthma history, there is eosinophilia, like in the term itself, eosinophils, and PNCA. Microscopic polyangiitis also, again, usually PNCA. So that is the difference. So that was about the different glomerulonephritis.